So I'm sure most of the people in this room have either donated blood themselves or you've seen when the big red bus rolls around campus. And those of you who have donated blood will know you have to fill out a big old form and note if you have any pre-existing conditions that could affect your ability to donate. So when I saw the big red bus, I thought, all right, I'll get past the fear of needles, I will give blood, it's the right thing to do. But when I went on the bus, I got my finger pricked, sat there waiting for a good 15 minutes, finally got called back to get authorized, and the nurse had never heard of the condition that I had written down on the form. And she had to call somebody else off-site, and they didn't know what it was either. And so in the end, I didn't get to donate blood. The condition that I had written down was Parkinson White syndrome. And it's not a very common thing. It affects less than 1/3% of the world's population. But I can guarantee that all of you know of somebody who has it. Marilyn Manson, Meatloaf, Michael Cera, and me. So I'd like to start out just explaining a little bit about normal heart function and then what's different about that in WPW, the symptoms that that causes, and how it's most commonly treated. So in normal heart function, you have a bundle of nerves up in the top right called your sinoatrial node, or the SA node, and it acts as your heart's natural pacemaker. It depolarizes somewhere between 60 and 100 times per minute, and sends an electrical impulse first across the atria, the upper chambers of your heart. That impulse is then amplified and redirected by the second node, which is the atrioventricular, or AV node. A layer of insulation in your heart prevents the electrical impulse from getting anywhere except through the AV node, which sends an impulse down the bottom of your heart and then up the sides so that the ventricles can contract and send blood to either your lungs or the rest of your body. And when you look at an EKG, that first little lump you see is the sinoatrial node depolarizing. The big spike is from the AV node. That really powerful, sudden, unified depolarization makes that big straight up and down spike. And then that second little lump you see is the contraction of the ventricles. In WPW, there's a fault in that insulating layer, and it causes part of the ventricles to depolarize a little earlier than they're supposed to. And so on an EKG, you get this little slope instead of that straight up and down spike, and the slope is called a delta wave. Not all people with WPW have symptoms, but everybody who has it will have a little delta wave on their EKG. So what it looks like is there's a small extra accessory pathway, it's called, in your heart that causes this part around the accessory pathway to be depolarized too early. So by the time the actual impulse arrives, it's already repolarized, and it sets up this reentry circuit where that one impulse keeps recirculating around instead of actually letting your heart beat normally. And so what that can cause in about 40 to 80% of people who have WPW is what's called AV reentry tachycardia, which means because of the reentry circuit, your heart beats way too fast, somewhere between 150 and 250 times per minute instead of 60 to 100. And the result of this is when there's an episode of the tachycardia is you get chest pain, heart palpitations, meaning you can feel your heart beating in your chest. You might get dizzy, some people faint or get out of breath. And in really rare cases, the exact prevalence isn't actually known. It can end up resulting in cardiac arrest, which is why in people who've experienced the rapid heart rate, it's important to get it treated. And the way that they treat that is with what's called catheter ablation. It's a permanent solution to the problem, and what they do is they take a very thin tube and they stick it in a vein either in your neck or down in your thighs, and they snake it up through your vein into your heart. And what they do then is they have electrodes on the end of that catheter that can sense electrical activity in your heart. They find where the accessory pathway is, and then they destroy it with a laser, with freezing, or with radio waves to make a scar there. And since the scar can't conduct electricity, the problem is solved. And the nice thing about the ablation is it's not open heart surgery. Since you don't actually have to get cut open, it's a lot less risky, it's a lot less painful, and there's a lot less recovery time. The maximum recovery you would need after this is you stay overnight in the hospital and maybe can't do any heavy lifting for a little while. But other than that, you're pretty much good to go afterwards. There's no side effects that there might come from drugs treating it. It's a very low-risk procedure. It takes around 2 to 8 hours total, and then, like I said, just stay overnight in the hospital and you're pretty much fine afterwards. It's a permanent treatment. So that is really all I've got to say. Give you a little biology lesson.